We aren't trained to analyze labs at the level we really need to. We're like accountants.
Mhm.
You read growth hormone level, good, bad, whatever. We read prolactin level, good, bad, or other. We read T4 to T3 conversion, good, bad, or otherwise. Well, it turns out that all three of those, growth hormone, prolactin, TSH also, and T3, T4 are all interrelated. So you can have patterns that change growth hormone that will influence prolactin, influence thyroid stimulating hormone, influence the conversion rate of T4 to T3. And if you don't understand these relationships, associations, you will over or undertreat.
You're listening to the Lifestyle Medicine Podcast with Dr. Ivan Rusilko, brought to you by Access Lab, where we explore new perspectives at the forefront of personalized healthcare.
Hey, how's it going? It's Dr. Ivan Rusilko here, the host of the Lifestyle Medicine Podcast, sponsored by Access Medical. If your doctor's not doing diagnostics, he's not a doctor. And I got a special guest today, and I'll tell you what, we are getting into the neuroendocrinology world like you can't believe today. I'm very excited to have Dr. Mark Gordon with me today. Thank you so much for coming.
Hey, Doc, it's a pleasure.
Heck yeah, man. Again, so just to kind of introduce you, which I don't think you really need any introductions with your history. But again, so you started out in family practice or family medicine.
Correct.
You kind of evolved into this whole aspect of clinical orthopedics, cosmetic dermatology, sports medicine, and now I love the idea of interventional endocrinology. Can you explain that for me?
Well, interventional endocrinology was my first book, and it was because I could not call it anti-aging medicine. Because
I hear you.
I was working in a very academic environment, and in fact, I had one of my colleagues was in the same building as I was, and he says, "I hadn't seen you for a long time. You're not at the hospital." I said, "What are you doing?" I said, "I'm doing anti-aging medicine." He changed the conversation, says, "So how's your dog? How's your wife?"
Immediately.
And
just like
immediately.
that.
So I knew there was something wrong. So it made sense, interventional endocrinology, because anti-aging medicine, or any term you're going to put onto that, it's about intervening in a unique area of the biochemistry or the neuroendocrinology of the body. And hormones are very, very good. I was a professor, associate clinical professor at USC, and Caleb Finch was one of my gurus who wrote one of the earliest books on neuroendocrinology. And that turned me around to understand that neuroendocrinology is a valid area where the brain has its unique assortment of hormones, which are the exact same ones below the neck.
Below the neck, yeah, exactly. So could you explain the difference between neuroendocrinology and endocrinology?
Sure. It's a tough one for me because I try not to be acerbic towards either one. So in endocrinology, it deals with the glands of the body and usually below the neck. Yes, we know the regulatory system, the hypothalamus and the pituitary, but in the neuroendocrinology that I've been working in since 2004, it takes it to another step. And that step is how the hormones made in the brain influence neurological functioning. And it turns out it's not just neurons or neurology, it's neuroimmunology, it's neuropsychiatry. Because in my writings, we talk about how we now understand how proper levels of hormones in the brain influence inflammation. And in the premise of most of my work is anything that causes inflammation in the brain will disrupt the chemistry of the brain, leading to cognitive, emotional disruption. And that's what we've been proving again and again. We have 12,218 people who have gone through our program, and it's not permanent. Our treatment is do testing, do proper testing, 28-point biomarker panel, which, thanks to my involvement with Access as medical director of education, was able to develop this panel over a period of about 14 years in total.
I saw you actually called it the Millennium 28-point biomarker panel, correct?
Oh, yeah, 28-point biomarker,
Cool.
Dropped the millennium, but yeah, I know I did it. Maybe you don't know, but now you do. But
Touche.
it's a 28-point. Actually, there are 24 markers that are measured and 4 of them that are calculated. And the standard problem, or we aren't trained to analyze labs at the level we really need to. We're like accountants. You read growth hormone level, good, bad, whatever. We read prolactin level, good, bad, or other. We read T4 to T3 conversion, good, bad, or otherwise. Well, it turns out that all three of those, growth hormone, prolactin, TSH also, and T3, T4 are all interrelated. So
Mhm.
you can have patterns that change growth hormone that will influence prolactin,
Mhm.
influence thyroid stimulating hormone, influence the conversion rate of T4 to T3. And if you don't understand these relationships, associations, you will over or undertreat.
True, and so, like, because every single doctor, their friends, their sisters, their second cousins are trying to jump into this industry right now. And how many doctors do you think right now who are taking on things that you treat currently, who are basically coming into this industry not understanding these different types of protocols, these different type of interrelationships, and just do you think they're a majority of the industry is actually doing more harm than good because they don't understand these things or they aren't testing for it?
Well, I agree with you. They are doing more harm than good because you have a patient who's low in testosterone. Why is he getting 200 milligrams a week? As opposed to what I ask docs who come to me, I say, okay, how much testosterone does a healthy 25 to 35-year-old make per day? If
Hmm.
they answer it, I'll respect them. If they don't
Okay,
answer it, I'll send them back to the drawing board. It's 4.1 to 10 milligrams a day, 28 to 70 milligrams a week. So why do we use
massive amounts.
150, 200, 300? Because they treat everybody like a bodybuilder. Because a lot of our early science, our early clinical experience on the street from Bubba selling, the Mastrolone or the Brexalone or the whatever it is, the
Uh
testosterone on the corner, yeah, hey, how much of this should I use?
Exactly.
Uh,
Oh, Google.
yeah, yeah, Google it, yeah. But you can't find in Google exactly what it
Mhm.
is because you find the fallacies as well. And, I only work with the military, and I'm freaking out where docs at the military say, take 1 cc of a 200 milligram per cc. That's 200
Recipient A.
milligrams. That's why they burn out their gonadal, hypothalamic pituitary axis,
Exactly.
gonadal
The whole
axis.
the whole negative feedback loop, because I mean, I also do a lot of the, consulting and stuff like that, and to find how many physicians don't understand the whole aspect of a positive and negative feedback loop is just bananas. I mean, everybody's coming in now, and I think being in Miami Beach, the sexiest city in, the world, you
Yeah,
know what I mean? So everybody's trying to look like a bodybuilder. And it's just scary to see, especially with I call them false prophets in this industry right now, come in, pay $10,000 and get testosterone and growth hormone and walk away,
yeah,
which is, it's terrifying. Yet, you have 1 million followers and you have this celebrity on your thing. Everybody thinks you know what you're doing,
right,
and you're doing just that. The amount of people I've had to fix who are just on testosterone cypionate or a nanthate at some stupid dose that aren't paying attention to the actual negative feedback loop at the actual brain versus the actual gonads. It's it's
right,
it's, it's sad actually.
yeah,
And these are young kids. These are in their 20s and 30s who are still looking to have kids. So, the amount of damage that's being done by physicians who don't understand the industry, it's pretty scary. You know what I mean? And in this industry right now, the whole traditional aspect took a gigantic hit with the whole COVID thing that went on. So everybody's now looking for trusting physicians. So they're turning to the wellness industry. And unfortunately, all those physicians from the traditional medicine snuck over here and are masquerading as biohackers and,
right,
like you said, anti-aging doctors. And it's
right.
it's it's pretty much given us all a black eye.
Yeah. And that's why we need to educate our patients or the people out there to understand what are some of the fundamental questions that need to be asked of the doctor. Okay,
Exactly.
and that's it. And to give them the license to be able to do that. There are people out there who, but he's a doctor. He should know. Well, he should know how to make money, right?
Exactly.
And
It's a
that's the
business,
issue. It's a business. People don't understand. Since the insurance companies started doing their stuff to us
Mm.
back in 1975, we learned that we've got to defend ourselves to some degree
Mhm,
financially, but not to take advantage of the patient, the clientele.
mhm.
So, what we do in Millennium is I work with the military and my daughter works with all the civilian population from NFL, NHL, Hollywood, skateboarders, whatever.
Hollyweird for sure.
Hollywood, yeah. I'm medical director of CBS Bradford Studios for 23 years.
God bless you, man. God
It's
bless you. The
it's
stories.
Hollyweird. So I've met a lot of nice people
Oh,
and a
I
lot of
bet.
people I've kicked out of the practice because they just don't understand, you know, treat me nice. Don't screw with me,
No,
They're
trust. I hear you,
entitled,
man. Mhm.
entitled. That's where
I
I close the door.
Your mouth or God's ears, you know what I mean? Like,
Yeah.
I'll tell you
So
what.
so anyway, with the program that we do for anyone, whether or not
Mhm,
it's military or a civilian, is as you said, the first thing you need to do is the laboratory testing. And unfortunately, we see some really shoddy, poor labs. Someone comes in and they're stating all the things that seem so accommodating for low testosterone. So they do free total testosterone, they might do luteinizing hormone, they might do
Mhm.
estradiol level, but that's 4. There are
You need
20 other hormones that support
exactly,
that.
man. You need IGF, DHEA, cortisol. You need all those, man. You
All
need a
that
full
stuff.
picture. It's
Yeah,
a
you need
puzzle. You know what I
you
mean?
need the puzzle. Also, you ask most docs and you say, "Okay, is it primary, secondary, or tertiary hypogonadism?"
None of them can get it. None of them can get it. I love
Uh,
that aspect.
what is primary? What is secondary? What's tertiary? Well, I found in the military, a lot of the guys, because of blast wave trauma, they have an interruption of the arcuate periventricular nuclear area of the hypothalamus, which
It's more
leads to
primary.
a problem with prolactin. What happens? Prolactin loses PIF,
Mhm.
prolactin inhibiting factor, which is also called dopamine, and their prolactin level goes up. Prolactin elevation shuts off luteinizing hormone,
Yep.
so they become testosterone deficient.
Mhm.
That's a common one. Another one, which I just dropped the new article, it's called The Two Eyes of Hypogonadism, the story behind ibuprofen and inflammation. A lot of
Oh, I
people,
like okay, go on.
you can
You have
go
my
read
full
it.
attention right now.
Yeah, I just put it up. Anyway, what the paper is about, and I talked about it to Congress in Task and Purpose in December of last year, was that operator syndrome. Operator syndrome is the special forces when they've been under a lot of stress, they've been exposed to a lot of blast wave and
Mhm.
everything, they become testosterone deficient. So Congress is pushing the DoD, Department of Defense, the Veterans Administration, VA, to do testosterone testing, and if they're deficient in testosterone, to put them onto testosterone. Wrong thing.
No,
Wrong thing. What they need to do is learn that ibuprofen, which is the index chemical for all the nonsteroidal anti-inflammatories. We're just using ibuprofen to represent the entire population of nonsteroidals. What it does, two things. It blocks the ability of the brain to turn on the hypothalamus to make gonadotropic releasing hormone to
okay.
stimulate the production of luteinizing hormone. One. Two,
Mhm.
it blocks the Leydig cells receptors so
Got it.
that the luteinizing hormone
LH.
that gets to the LH, that gets to the Leydig cells and binds to the AR receptors, there's no transcriptional signal being sent to the nucleus to take cholesterol and make it into testosterone. So you've got
Mhm.
high upper level and a lower level involvement, and it happens in women through their thecal cells as well.
Oh,
So
for sure. That's fascinating.
there's that article started in 2017. The first article came out talking about ibuprofen blocking the production of testosterone. And the pattern it gives is primary hypogonadism. So everybody says, "Oh, your testicles are burnt out." I'm 18.
Yeah.
How'd I burn them out? Because
Touche.
it's called compensatory hypogonadism pattern. High luteinizing hormone, low free testosterone, which fits also primary
Yeah, primary. Yep.
hypogonadism. So all you
Yeah,
do is
no.
you ask the patient, "Have you ever had head trauma? Have you ever used lots of ibuprofen?" "Well, I played soccer between the ages of 14 and 18, and I was on ibuprofen all the time, or naproxen, or
Mhm.
Feldene, or Telectin, or whatever drug is in the
Yeah,
NSAIDs group."
NSAIDs.
So the treatment in 2017, the article came out. 2018, I read it and it turned my entire world around. I
Mhm.
stopped using injectable testosterone. What did I do? Started fixing the problem. How do you fix the problem? Selenium and either eclomid or clomiphene citrate.
Yes, I'm a huge fan of, Englomifen, huge fan of it.
When
I
did you
think
start
that's
using clomiphene?
I started using Clomiphene. I switched over from Clomiphene because again, I came back. I used to be one of those guys doing the stuff. I have a whole history of being Mr. USA in bodybuilding, so that
Yeah.
was back in the day. So I started using Clomiphene. I'd say probably in 2016 or
Okay.
17 or something like that. So
Okay.
a little bit back. But I mean, I was on the Clomid aspect as well, and then I kind of, started doing my
Yeah, but
research because I believe every physician needs to be a student of life,
right.
and it's kind of unique because I see you're also coming out, which is going to kind of circle back to what you just said right there with basically an office assistant, so kind of an AI that's going to help kind of go through, and you just went through so much biochem, organic, all kinds of good stuff on it. How many people do you think, and the way you've structured it was, I mean, for the doctors who actually understand what you just said, I think it's fascinating how you put those two together. With your AI system, is that what you're kind of aiming to do, is kind of giving and empowering physicians to look past just, HCG and clomiphene, this, that, and the other, but look at the actual problem itself? Or is it more about just diagnosing, saying, listen, you check testosterone, free testosterone, this, you need IGF, you need, the different thyroids, all that kind of stuff. What is that system about? Because I find it fascinating.
Yeah, the Millennium Office Laboratory Assistant, we just call it MOA. What it is an artificial intelligence program. It took me 9 years to write. I got my certification from MIT in artificial
Amazing.
intelligence and healthcare in 22 March, and then September, after the professors and my colleagues in the class, looked at it and played with it and said, this is great. They couldn't find anything wrong. That's why I took the class, to make sure it worked.
Hell yeah.
So what happened was I released it September, and we have 127 facilities in 14 countries. We just added Thailand, Philippines, Australia, New Zealand to the list. And what the software does, and the reason for developing it was when I came out with my TBI book in 2015, TBI, Clinical Approach to Diagnosis and Treatment, it had a chapter on how to run labs. But I got a lot of complaints. Damn, that's too much. How do I know how to use it? How do I know how to interpret it? So I had already started notes back in 2010. The book came out in 2015. So I started consolidating it into a software package. And what it does is it analyzes in a multi-tiered matrix, which is 4 times 10 to the 13th power. So if you take 28 to the 28th power, that's where you get that number. So what the software
Fantastic.
does is it analyzes every hormone against itself and the next. So growth hormone against IGF-1, growth hormone against IGF-1 and binding protein 3, growth
I love
hormone
it.
against DHEA, growth hormone against testosterone, thyroid, and so forth and so on.
Cortisol.
And then the next one, IGF-1 against binding protein 3, then against, so it's a cross-correlational matrix, and it gives you a level of incredible answers and a 12-page report. It gives educational cues for the doctor, because this is to help the doctors to embellish their skills. It's not about just selling a software. It's about helping our colleagues get better at the skill that they're professing to know.
Exactly. No, very true.
You and I both know that there are a lot of people out there, not to disparage anyone, but there are a lot of people out there who barely know what they're doing. They say testosterone's elevated, that's it. But why is it elevated, or why is it low, or why is this happening? My question is always why.
Exactly. And I think that's the biggest thing that we as physicians have lost throughout the thing is what makes it better or worse? How is your sleep? I mean, the basic stuff that I think we need to ask where, I tell everybody with Access, and again, it's nice. I do a lot of their talks and everything, and they
Right.
help me to kind of construct the world's most in-depth blood test, I guess you would say. So we have patients flying from all over the world and do this. We're testing heavy metals, natural killer cells, all this kind of stuff. And it's just kind of unique. You'll sit there and like a physician will call me up from Cornell and be like, why did you do this for my patient? Because the types of patients I have armies of doctors with them. And it was funny. I think I did an article, either for Forbes or Playboy. And it was entitled "The Most Hated Doctor Among Doctors." And I kind of wear that these days as a badge of honor, because when you're empowering not only the physicians, but other physicians to kind of question doctors who have just sat there and said, oh, your cholesterol's high, let's go on this and this and this, or you have diabetes, just take this, as opposed to what are you eating? Should we be treating cholesterol, or is it high sugar causing the issue? So, I mean, what you're doing with this test, and again, off camera, we have something similar going on, so I'd love to chat with you about it.
Okay.
I think it's fascinating because, I think that's what's needed, not only to hold doctors accountable, available to what they perceivably know, but also even empower patients to ask the right questions, which is probably what every doctor dreads. You know what I mean? Like, you want an informed patient is either a very good patient or a pain in the ass. But I think this day and age, with so much information being available, AI, my first podcast I did was actually called AI, the Good, the Bad, and the Ugly, because there's some great stuff with it, and there's also some terrifying things about medicine and AI.
Yep.
But I think with this whole aspect of how you're basically interconnecting the hormones themselves is very unique, and I think it's going to take a lot of people to school, which is awesome about that. So kudos, I'm very excited that.
Yeah, the whole purpose of, another layer to the purpose of the software is to help get our colleagues to be very accurate. You know, the panel, the Access panel, I know the LCMS and some of their other technology, whether or not it's chemoluminescence or ELISA testing, but no RIA. What it does is it gives a skill set to a doctor so they can do much better at outcomes. And that's what it's about.
Efficacy.
We've
that's one of
got,
those important things.
in my military, having guys who are given labels of multiple sclerosis, PTSD, Parkinson's, Alzheimer's, we reversed it all by correcting the inflammation and by correcting the hormonal deficiency. You know, because a lot of times the perception or the understanding of hormones is that it's a sex hormone. Well, it turns out they modulate all our inflammatory immune system.
For sure. Yeah,
so
you are your hormones. You're nothing but a collaboration of your hormones. Everything else is just structure. You know what I mean? What are your thoughts on things like neurotransmitter testing dopamine through the urine, testing that kind of stuff? You're not a fan?
No, I use a surrogate marker.
Okay.
So
all right.
Why do I have to test dopamine when the direct relationship is prolactin?
True. No, very true. Well, what about things like glutamate and GABA? Would you be testing more of the things like tyrosine and that kind of stuff?
What regulates GABA?
Yeah, so you're the actual precursors is what you're looking through.
Not the precursor. What regulates it?
Well, again, sleep cycles is a big one.
Pregnenolone, progesterone, allopregnanolone. So if you're not generating it, let me give you an example. Just got finished with 2 veterans, and one of them was first time in some first laboratory. And I asked him, so how many hours are you in bed? He says, 10 hours. I said, oh, that's a long time. How many hours of that do you think you sleep? He said 5 to 6. I said, when you wake up in the morning, do you feel good, bad, good, fair, or poor? He says, poor. I said, what does that mean? It takes me a while to get up and running and my brain isn't going. I'm looking at his pregnenolone, progesterone levels, and they're low. Because they're low, you cannot generate GABA. Because they're low, you have higher anxiety and also something called peroxynitrite, which is a nasty, nasty RN reactive nitrogen species that destroys enzymes in the brain that increase your risk for Parkinson's. This is all connected, okay? But the majority of people aren't aware. My job is not to say you're a bad doctor. My goal is to, here's the knowledge. I've spent 44 years in medicine, 30 years in this field, 19 years with the military, developing, testing, and have the results. So it's really of one that I want to play it forward. I want to offer it to them. And any of our access doctors who are on this who want to play with the software package, the Millennium Office Assistant, they can go to my website and they will be gifted with a month to 3 months of free use of the software so they can see what it is. So they go to Millennium App, app.ai, and they'll see a little box up there. It says enroll. You click it. It shows you free. It says 1 month, but if they're with access and so forth, we can talk on the phone and get them a extension on it. Some of the docs contact me and I'll make time, 15 minutes to go over and give them a quick run through of the program, walk through. And I know it's very simple. All the software I've built since I was 18, now 72, is all about
great, man.
user interface. Okay. User interface. How easy. So I've got 3 daughters, 2 are docs. One of them is not a doctor. I gave her the software. She comes back in 5 minutes. She says, Pop, that's a cool program. I didn't have to walk her through it because it's intuitive.
I love that. Common sense based, straightforward.
It's intuitive.
I love that.
Straightforward.
Does the system also suggest protocols, or is it just simply
Yes.
making connections? Oh, it
Well,
does. And do the protocols involve hormones, peptides, nutrients, IVs?
no,
What else included?
no IVs. That's where the
Okay.
doctor puts his spin into it.
Okay.
It includes key nutraceuticals,
Okay.
It includes Clomid. It includes a growth hormone secretagogue called
Okay.
secretropin or dinotropin. They're the most cost effective, and they have 24 years of clinical application.
Fantastic.
Okay.
I love that.
And hormones, testosterone, thyroid is all incorporated into that. One of the things that happened, we have a psychiatrist in Punta Gorda, Florida,
Okay.
on the West Coast, and we have got a center in Hawaii, Jason Kiefer and Dr. DeMaio in Florida. And independently, she calls me. She says the laboratory results suggested this patient had a pituitary adenoma. I said, so what did you do? It told me to do an MRI with contrast. I did it. So what happened? I found the tumor. In Jason, same thing. The software looks for unique patterns that most docs may not know about. And it's not just growth hormone prolactin, it's thyroid, gonadotropic releasing hormone,
No,
it's FSH, LH, and it tells
everything.
you. And it says suggestions. Also, in our military, a lot of them had very high, they weren't on any hormones, taking no supplements.
Okay.
Their DHEA level was twice normal, and their testosterone level was very low, first
Okay.
quartile. What caused it? These are military guys. What are they doing? They had Fort Bragg. They're doing close quarter combat. They're doing, urban combat training.
Sleep
And they're
deprivation and
exposed.
everything.
Say again?
Sleep deprivation and all kinds of craziness.
They're exposed to their own plumage from the rounds. Mercuric chloride in the primer,
That was my question coming up.
lead
Exactly.
coming out. So what does it do? It blocks 3 beta and 17 alpha hydroxylases, steroidal hormone hydroxylase. So it blocks the enzymes that converts the DHEA to testosterone from 2 levels. So what
I love
happens
that.
is DHEA, and the system will tell you, hey, the pattern suggests heavy metal toxicity. Go run a test for mercury, lead, and whatever.
I love that. That's fantastic. I was going to ask you about heavy metals, like hidden pathogens like chronic EBV, Lyme, things like that.
No,
So that's great. That's super great that your system kind of sit there and do that. It's very interesting to
and
me
it's
too.
being
So
every
kudos.
6 months, it's being updated. I'm adding to it now the ibuprofen, so that
the paper.
even if they used ibuprofen, it will block for a long period of time. How long is long? I haven't the foggiest. But it will block the ability of your body to respond to luteinizing hormone, so you can't make testosterone. So the doctor who is unaware of this relationship will go ahead and start treating with injectable testosterone. We don't use any.
Yeah. No, it's
It's
fantastic.
purely
You're correcting the problem. You know what I mean?
right,
Like you're swimming upstream, not
right. We're
band-aiding
not creating the
hemorrhages.
problem. We're not
Exactly. No, that's
worsening,
fascinating.
digging a deeper hole. And that's what
Yeah.
I find. I mean, I've got young guys who are burnt out. Their doctors burnt out their testosterone. They're infertile and they can't make testosterone.
Jeez Louise, my God. And we're seeing a much higher prevalence of that, whether it's the stress, whether it's everything else that's going on in this world. I have a clinic now in Bahrain, and it's unique. So I go out there,
Bahrain.
I open it. What's that?
Bahrain.
Bahrain. Yes.
Bahrain.
I'm trying to get all my accents down, man. It's
Yes,
tough.
you need Bahrain.
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 And it's unique to sit there and see, because you go out there and nobody's really doing this out there right now. So I brought this gigantic lab test in. And it was a battle with the actual lab company. They're like, why are you testing FSH and LH in men and all this kind of stuff? And it was really unique to see the prevalence of high prolactin in that. And I mean, literally, it's probably coming back, I'd say 90%. And I'm talking men and women who have high prolactin over there. And I mean, I don't see, in Miami, we'll see that every now and then off the clip. But when you have 90% of somebody come back in a population like that, it was a complete zinc deficiency and a complete magnesium deficiency over there. Everybody has those 3 markers going on. So I just think it's fascinating now that, not only with like systems such as yours, the AI that can go through and make these unique associations, now you can sit there and start looking at, parts of the world. You said you're in how many different countries with this now? 17?
14 plus 5 to add 19. We're in 14
Damn,
officially.
It's fascinating. Now, so I'm kind of curious to see now. Do you see any trends going on with that, or no? I mean, is it anything different? Is it across the board the same? Ah,
No,
okay.
what I do in Southeast Asia is I train other doctors and we set up medical centers. My partner for the past 18 years, Singaporean, lives in Thailand.
Okay.
He was my chairman, division head, CEO of
Okay.
the wellness center that built for one of the largest hospital networks in Southeast Asia from 2010 until 2013. So,
Okay.
yeah. So I don't get involved. I mean, 147 clinics, I only own one, mine. I don't want to have anything to do with anybody else.
So you're also saying you're a good businessman too, not just a great doctor. I love that.
Well, I don't know about that, but, they wanna use our products, fine, use the products. They want to access the license for the software, go for it, you know? And contract with Australia would be very good because it'll fund me enough money to add more veterans into our program. I'm self-funded, no one
Mhm.
gives me anything, I work to generate the funds,
Uh-huh.
to move things forward.
Which is amazing.
And then,
Absolutely
I don't know if
amazing.
you saw the movie Quiet Explosions, the documentary that was done on our work.
No, I haven't. No, no, no.
Yeah,
I'm curious.
it's not about me. It was
Okay.
my partner, Andrew Marr, and Adam Marr. Adam Marr was Apache helicopter pilot. Andrew, Green Beret, EOD, Explosive Ordnance and Demolition. He was blown up in his 4th tour of duty. Not a
Phew.
scratch on his body. 6 months later, he's on 13 medication, full-blown alcoholic and
Oh,
suicidal.
man.
He came to California, did Pepperdine, got his MBA, and now he's in law school in Texas.
Come on. What a
Okay?
story that is.
Yeah, and I've got a lot of guys who are physician assistant, nurse practitioners, major business owners. I mean, I take care of some interesting people, but,
That's fascinating.
yeah, and
So
it's all about
go
healthy hormones.
no, again, you like I said, you are your hormones, you know what I mean? Like, so how did you get started with the military? Did you serve, or is that just something that just you played on your heart chord there?
And from 1995 until 2007, I was working with NFL players. I did 2 ESPN Outside the Line, boxers, hockey, whatever,
Okay.
with head trauma. And in 2007, I went back to him and I said, "Look, guys, I've been reading a lot about the suicides in our military. I want to open up a separate division for our veterans." Not a single one of those guys helped to donate money. So I
No.
said, basically, goodbye. Politely, it's goodbye. As a New Yorker, you know what I said.
Yeah.
So
Yeah, I can only
so,
imagine.
yeah, so it took me from 2007 to 2009 to generate enough reserve funds.
Mhm.
So I had articles out there inviting any branch to come in. We pay 100% of their services. So that's what we did, 2009, and then Andrew Marr came on board 2015, and I started getting some of my patients were donating to his 501(c) charitable
Okay.
organization. One patient, 380,000. A guy that I podcast with a lot, he donated a good amount of money, and it helped to allow us to pay 100% for these guys until he and I went bankrupt in 2017, 18. And then so now I pay for 60% of their entrance into the program. And a year program, if they
Huh.
paid for it 100%, is like $5,000. And
Okay.
it's not a lifelong thing.
Yeah.
It's
That
I've got guys 3 months in and out, 6 months in and out. I just finished with a 48-year-old major out of Fort Hood in Austin, Texas. He was on 8 medications, not doing well. 6 months later, he's off all his medication. He's helping us to get a bill passed in Austin, Texas, in Texas. That's why I have a house there, and, I'm in Austin. In Houston, I have a house, but I go to Austin a lot to meet with the representatives. Last week, I was there talking with one of the representatives who I hope she will, help us. Yeah. So
no, it really is. I mean, it's good to see, like, when, physicians who specialize in a field such as you do, I mean, you're obviously considered a pioneer in neuroendocrinology that can sit there and kind of not only sit there and profit from it, but more importantly, kind of change a narrative, kind of change the way the industry is growing, which I think is fascinating. I think with everything going on right now, the amount of depression, the amount of issues with neurodegeneration getting earlier and earlier and earlier, and
right.
nobody really knowing why, that's probably the most prevalent field out there right now. I would say even more so than, immune systems and everything like that.
Yeah. Well, what I'm working on right now, a couple of articles that focus in on neurodegenerative diseases because we've been able to reverse multiple sclerosis. The patient did the video. I didn't. He
Mhm.
did the video, and he's talking about how in 104 days, he went from having problems with multiple sclerosis, no medication, to being in remission. He's been in full remission since November 2023. We've got Parkinson's, Alzheimer's, we've got some PSPs, the progressive supranuclear palsy, CTE. CTE is very similar to PSP,
Mhm.
but they won't acknowledge it. And it's because we address the inflammation and we address the hormonal deficiency caused by the inflammation. In 2013, they found the entire mechanism. 2013, inflammation shuts off astrocytes communicating with the hypothalamus, so you
Yep.
can't generate gonadotropic releasing hormone to turn on luteinizing hormone or follicle stimulating hormone. So it's in the literature,
Yeah.
and what we do is I do translational medicine. I read a ton of stuff. That's a medical term. So the the reading is incredible. The amount of stuff that I read, it starts forming pictures.
Mhm.
And being
Connections.
on all the stuff for brain function,
Mhm.
nutraceuticals, good hormones, N-acetylcysteine, some other things that
C-Max
maybe
is great, yeah. So,
some other
hold on,
people.
I'm curious.
Well,
Being the neuro guru, what do you take personally, if you don't mind me asking, for brain health and just keep your brain as healthy as possible? What
hmm.
nutraceuticals, what hormones would you suggest?
Well, I take pregnenolone,
Yep.
DHEA, NAD plus, NAD
Okay.
plus,
Injectable
magnesium.
or okay.
No, don't need injectable. You need
You're
good
doing
absorbing technology.
okay, good.
The field that I'm in is with the products we develop are nanoliposomal.
Liposomal,
So
okay.
you get a lot of all our products are nanoliposomal. Let's see what else. Multi-nutrient, multivitamin with
Okay.
minerals in it, plus 7 different magnesiums, N-acetylcysteine, NAC,
Mhm.
quercetin,
The glutathione.
copper, let's see, zinc, and it's very few products because we put them all together.
All in one, yeah,
Not
yeah,
all
that's key.
one, but we put what we can together for optimizing absorption. Let's see, Clomid, I take 50 milligrams of Clomid every 3rd night
Okay.
and get a good response there.
So
Let's see,
you said doing 50 milligrams every 3rd night.
correct.
Is
Well,
that what
we
you
did
said? Okay.
all my stuff is on my website. We did the
Mhm.
3-year veteran study on Clomid. In 2014, 13, 14, the DoD sort of like blocked testosterone in their active people, in their veterans as well, because they were afraid it was causing them to be hyper, causing them to be aggressive,
Oh,
causing
dude.
them to be it's the deficiency that does worse than
Yeah,
excess.
exactly. I was just
Yeah,
gonna say, I mean
yeah. So what we did was 3-year study, 2014, 15, and 16. 2014, my first review of the results was in January 2015. I had already been on injectable testosterone for 17 years, 60 milligrams of a blended testosterone we developed in 2001, 60 milligrams every Sunday for 17 years.
okay.
Doesn't suppress your LHFSH, lowers it, but doesn't suppress it. And I stopped that and went on to Clomid because the results were just unbelievable.
Oh, fantastic.
So what we did was we found what the lowest dose and the lowest cycling was. So we have people who are taking it 25 or 50 milligrams every 72 hours at nighttime, or 12.5 of Eclomid or 25 of Eclomid. But it's the
Okay.
pulsing of it. Why do you pulse it? If you give it too frequently, too close together,
It
it
kinda regulates it.
suppresses the luteinizing hormone receptors. You suppress it just like every other
Mhm,
receptor ligand system in our body. Hormone receptor, ligand. That
mhm,
will be a shutdown. And that happens a lot in growth hormone. That's why using things like semirelin, tesamorelin, ipamorelin, they're prone to a homologous downregulation, which is a system that occurs because giving too much too long will shut off the receptors.
mhm,
So you have to raise the dosing. Well, the problem with those drugs, those growth hormone secretagogues,
mhm,
is the fact that they're a single channel. Secretropin and dinotropin have 5 channels.
mhm. More
So you
angles
hit
needed from.
5 channels from the synthetic receptor, the garrulin, to the dropping of the arcuate nucleus and release of or periventricular nucleus, release of somatostatin. Arginine, very good for doing that. You can just throw in, 3 to 5 grams of arginine every night. You get a good erection and you increase growth hormone.
Sign me up for double. I mean, like
Yeah, give
shit.
me a double header on that. And it also drops blood pressure.
True. No, again, yeah, argine's one of my favorites. I mean, it really is. And again, the whole nutraceutical aspect of it. Unfortunately, in medical school, I don't know if it's the same with you. I mean, medical school doesn't really harp on nutrition hardly at all. I think I got 30 minutes of it in my entire time. So I actually had to go, while I was in medical school, go out and get my actual sports nutritionist degree,
Yep.
just to sit there and be able to justify understanding and prescribing nutraceuticals, which I think every physician, that's probably the most important thing you can get. I don't care where you're getting credentialed from, get a nutritionist degree, you know what I mean?
I did Jim Bell. You know Jim Bell in Florida? Dr. Jim Bell?
Oh, yeah. I know him personally. I've heard
I
of him.
did his class in nutrition and sports.
Oh,
And then
fantastic.
I did Cleveland Clinic with chiropractic because the chiropractors had it down. They
Yeah,
knew it
you're right.
before doctors.
They
And
did, man.
I like chiropractic medicine. Let's see, 35 years dealing with chiropractic medicine, and I ended up doing Cleveland Clinic for just their nutritional course.
That's awesome. That really is. My father was actually a chiropractor. So, I mean,
There you go.
I'm a big believer in it. You know what I mean? So, yeah, it was super cool. But yeah, no, I think what you're talking about, I think every physician needs to kind of, grasp to and actually gravitate towards, because a lot of physicians don't get excited when you talk about the actual biochem of it. You know what I mean? Like everything is such an immediate gratification. Like, oh, clomiphene does this, do this. It's just like, well, why does it do that? What is it acting on where? And I think once you stop thinking linearly and you start thinking multifactorially, I think that's where I think a doctor becomes a physician very
Yes.
quickly.
Yeah.
And again, with the whole 28-point system, I think that's fascinating. What are the 4 calculated markers that are found in that?
Yeah, we developed in 2005 a mathematical model called the EP ratio,
Okay.
estrogen-progesterone ratio. We do estradiol, estrone, and progesterone and
Yep.
pregnenolone. The relationship between these can tell us whether or not the woman has estrogen dominance or not. So
Yep.
when we have a woman who is having premenstrual syndrome or the premenstrual syndrome,
Mhm.
it's usually estrogen dominant. So this gives a mathematical number over the past 2005 to 2020 before we released it. It was 20 years of doing the crunching of numbers to see the model. And it turned out if you're 250 or less, you probably didn't have it. But when you're higher, 1,000, 2,000, 7,000. I had a woman, 7,000, who was bouncing off the walls, emotionally volatile.
My God.
And then my niece, my 18-year-old niece, had migraines. She was estrogen dominance, which causes migraines. So
Yeah,
we
for sure.
just
Yeah.
gave her progesterone, gone.
Fixed it.
So we treat that. So EP ratio is
Okay.
calculated by the system. Testosterone, you'll call it bioavailable. We use what's called a 2% rule. So 2% of total testosterone should be the bottom of your free testosterone. So if you have 853 of total testosterone, 17.06 should be your free testosterone. But if the free testosterone is less than that, you got to look for where it's going. And the most common places it goes to is sex hormone binding globulin, conversion to estradiol, DHT, and so forth and so on. And this whole thing about sex hormone binding globulin, if you just learn the biochemistry of why sex hormone binding globulin goes up, it's under the direction of DHT mostly, and estradiol secondarily. So you don't chase after sex hormone binding globulin, you drop the
DHT.
DHT.
Exactly. No, it's
But
straightforward. I mean, like, it's
why
a
they
drip down.
they want to use aldomet. What is it? Aldosterone. They want to use
Oh,
aldosterone,
Jesus. Start messing
Come
with your
on.
salt and all that shit. Yeah.
Fix the cause, not it's like
Ocean medicine,
all the docs want to do, treat the psychiatric aspect to head trauma with antidepressants and everything. Why don't you go fix the problem? That stuff,
Couldn't agree more.
peroxynitrite, destroys serotonin and melatonin and increases something called kynurenic acid in the brain, which, according to studies out of Japan, Dr. Nikimura, he found that the higher the level of this kynurenic acid, the more you are depressed. Serotonin, 2017, 18, 19, what did they find in England? That there was no direct correlation with serotonin and depression. They had people with high levels of serotonin who were depressed. They had people with low levels of serotonin who were normal.
Mhm.
So they said it's all
Exactly.
off the boat. So what is it? It's the fact that peroxynitrite blocks L-tryptophan going to serotonin, going to melatonin, and it backs up. L-tryptophan becomes kynurenic acid.
I love it,
Okay?
man.
So
I
I
love
work
it.
at a molecular level.
I
That's
do
where
it. I love nerding out on this stuff too, so it's
right.
good. It's good.
I write a lot of nerd stuff. Now I'm rewriting things in like scientific American language so that people can read it because I'm reading it and say, damn, this is just too deep.
Okay,
You
you're
know?
too far down the
And
rabbit
that's
hole,
why
right?
people aren't reading a lot of it. The hardcore people, like the guy I'm meeting with in a couple of minutes, who coined the term operator syndrome. Okay,
Okay.
well, that's why I'm meeting in 10 minutes.
10
So
minutes. Okay. Well,
10
very
minutes.
cool. Very cool.
So
Well, I'm going to give you some time. So I always like to ask everybody 2 questions. Okay.
okay,
It's a 2-part
one,
question. So number 1, so for all the physicians or healthcare practitioners who are listening to this podcast, what would you say is the number 1 thing that they should take away from it, from a healthcare business slash efficacy for your patients type view?
well, the most simplistic thing is do the right thing for the patient.
Love that.
Okay, that's
Yep.
number one. But to parallel that, take advantage of what I'm offering you. You can get access to the MOA and use it for free to see if it's something that makes sense to you. Also, the software was originally written just for Access laboratories because Access has a quality of testing that Quest doesn't have, that LabCorp doesn't have, that a lot of the labs that I've interacted with do not have. So take advantage of it. Just go to
I love
Millennium,
that.
MILLENNIUMAPP app.ai. Just Google it and you'll find it.
I'm going to
That's
do it
number
right after
one.
this. I love that.
What's number
I
two?
love. Number 2 is, so there are a lot of people who are not healthcare practitioners or people in the industry who are going to be watching this as well. What would you give? What's the best advice you can give to a patient who's out there looking to get into this industry, who's coming from a broken traditional medicine type setup? What would be the most important thing when it comes to selecting your doctor as well as selecting your direction of care in this now budding wellness industry?
Yeah. You've got to learn what it is that you need. And the only way to do that is to read and say, okay, do I need testosterone? Do I need growth hormone? Do I need DHEA? Do I need pregnenolone? And then find a doctor, find out if they'll give you a 15-minute consult on the phone. And you ask question, what's your feeling about the use of pregnenolone? I don't know. I don't use it.
Next,
What's your,
swipe left.
yeah,
Swipe left.
when you replace testosterone in a male who's 50 years of age, what is the usual dose?
Yeah,
And
exactly.
how
Huh?
often?
200
Yeah.
milligrams.
And how 200, 100. As I said, a healthy 25 to 35-year-old male makes 28 to 70 milligrams a day, a
Mhm.
week.
A week.
So around, I think we max out at, in a rare case, at about 100, but the majority of our patients in a week are getting 40 milligrams twice a week. It's at
Mm.
every 72-hour. Why? Because if you understand the biokinetics of hormones, you know that testosterone cypionate is 36 hours, enanthate is 48, and propionate is 2 hours. So why did we develop in 2001 a blended testosterone, which has propionate and cypionate in it? Because you want it to
Exactly.
get into the system so you feel good. What does it also do? It means the amount you use is far less than the slower, they try
Releasing.
to compensate. Well, if I give you 40 milligrams of testosterone cypionate, it's going to take 36 hours for it to dissociate from its ester to start getting into your brain.
Mhm.
Everybody thinks it's what it does in the muscle. It isn't. It's what it does in the
The
brain.
brain.
DHT in the muscle, DHEA in the muscle by increasing the glucose receptor so you get sugar in it and build better glycogen.
Mhm.
But it's
Stronger.
in the brain that gives you. I mean, the grandmother, the 73-year-old grandmother who picks the car off of her grandson, how is she able to do it? The
Huh.
chemistry of her brain allowed her muscle stretch factors to be zeroed so you don't get the stretch that causes you to shut down. It's a feedback, gamma
It's
effort,
a feedback. Exactly. No,
gamma
that's
effort. So
fascinating. You know what I mean?
anyway, so the same thing in the mind. Testosterone allows you to lift better because you're not having that reflex to tell you to stop lifting.
No, that's great. The whole mind, body, emotion aspect, which I think is the most important thing in medicine. You know, we are a collaboration of our weakest link. And as cliche as that is, it's true. You know
I
what I
like
mean?
cliches. I like that
Yeah, yeah,
cliche.
yeah, man. Heck yeah, me
So,
too.
so Doc, what you're going to do is you're going to go to the website and you're
Mhm.
going to sign up for the free
Do it
MOA.
right when we get done here, I promise.
Okay,
And again,
for
there's
free
a couple things I want
MOA.
to chat with you about.
And then what will happen is I'll find time and we'll connect and I'll walk you through it to accelerate you. You're already using Access. You
Yep.
don't have to use all 24 markers because I spent a year rewrote it so that it is in the beginning you had to use all 28 or all
Okay.
24. I rewrote it so you can use one test and it'll give you a report. And
Okay. So yeah,
it's a 12-page report that includes a predictive treatment protocol. What a predictive treatment protocol. If you're low in T3, what do?
well, you obviously figure out why you're low in T3. I think is the most important
They don't
part. You know
tell
what I
you.
mean?
They don't tell you.
I
You
love that.
replace it. The
Mhm.
treatment form of it is you replace it. If you're low in DHEA, what do? You treat it and tells you how
Mhm.
much to give based upon an analysis of a multitude of points.
I love
So
that.
it might be
Absolutely
15
love that.
milligrams, 25 milligrams, 50 milligrams, okay? Pregnenolone. It'll look at progesterone, pregnenolone. It'll look at the pregnenolone steal syndrome,
Okay.
which a
Oh
lot
yeah,
of
no, for
docs,
sure.
I got attacked by traditional docs who didn't believe in pregnenolone steal syndrome until I
What was their
gave them,
basis?
what's that?
What was their basis? Why do they attack you?
Ignorance.
Yeah, there's a lot of that in traditional medicine.
That's it. Just it. Okay. So, my goal is to try and provide to anyone who asks help so that they can step up to the next level. It's not to say that what they're doing right now is not good enough, but I'm saying that in the patient population, you're going to find that you're going to need to do that level of intervention and
Mhm.
assessment in order to be the very best. What we
Exactly.
do is on an annual basis, we do an assessment. Every month, we do assessment of our patients with something called an MPQ, monthly program questionnaire. And at the end of the year, we take it all together. We have it statistically analyzed, not manipulated, analyzed. And when I went to talk to SOCOM, which is command for the military, Operations Command, we're at 78.3% of the people are 50 to 100% better in 12 months.
Wow, that's a hell of a stat.
It's very good. And, in my dialogues with Walter Reed and Georgetown University, one of the top guys was following us for 2 years, and he said, "You've got better outcomes than the military," but he can't help me. I said, "So
Go
what good are
figure.
you? What good are
Red
you?"
tape, man.
Yeah,
Red tape. You know what I mean?
I got it. So I'm not relying on anyone other than our community of active doctors and the connections I, have with military podcasts, with Rogan, with Montel Williams, with boxers and so forth, and just trying to do the very best so they can live a really high quality life
I
because
love that,
that's the
man.
key.
And you definitely have a friend in Miami Beach. I definitely looking forward to following up with you. I am going to sign up immediately after this. And again, I
Okay,
just want to say thank you so much, man. This has been such an educational one,
super.
not only for the listeners, but for me as well. So to impress me is a hard thing to do, sir. And you definitely did that today. So
Thank you.
awesome, man. Awesome. Thank you
Okay,
so much, man. It was awesome.
thank you too.
Have a good one.
Thanks for joining us today on the Lifestyle Medicine Podcast. At Access Labs, every innovation we pursue is driven by one bold purpose: making personalized medicine more practical and accessible for patients and providers. If this episode sparked new ideas or challenged how you think about patient care, awesome. Follow the show and share it with a colleague who's ready to level up their practice. Head over to our website at accesslabs.com and register your practitioner account today. You'll get access to over 1,000 routine and advanced biomarkers with 24-hour results. When signing up, select Lifestyle Medicine Podcast as how you heard about us and score 10% off your first invoice. Oh, and don't forget, drop us a review. It helps more practitioners like you find us. We'll see you next time.